Well, good evening, and again, welcome to Toolbox Tuesday. And today we are featuring Melissa Miller, who will talk about the 988 Lifeline and across the continuum. Um, my name is my name is Renee Powell. I'm with Oklahoma Family Network. We also have Tammy Burleson here. She will be assisting with just making sure things go smoothly with the Zoom. But our featured guest, Melissa Miller, is the Chief of Policy and Provider Regulation at the Oklahoma Department of Mental Health and Substance Abuse Services. There, she identifies and implements strategic policy initiatives for the state's behavioral health delivery system and oversees the department's provider certification and provider contract compliance divisions. Before her work with the department, Melissa served as Deputy Director at the Oklahoma State Department of Health, managing high priority policy and health initiatives. She also worked for the Center for Learning and Leadership at the University of Oklahoma Health Sciences Center, providing training and technical assistance related to developmental disabilities. Melissa has a bachelor's degree in social work from Anderson University and a master's degree in social work from the University of Oklahoma. And without further ado, I'm going to pass it to Melissa. Thank you so much for being here.
Hi, everyone. Good evening. I'm really excited to get to be here, and I do recognize a couple of faces, so that's kind of nice. But yeah, a long time ago, feels like I'm getting older and older. I did work for the Center for Learning and Leadership and worked with OFN a little bit at that time, and so it's always nice to kind of come back and be with you folks again. So thanks for having me. But like Renee said, I work for the State Department of Mental Health and Substance Abuse Services. And I do a lot of work with policy, including Medicaid policy, and then a lot of our provider compliance divisions. And really today, I'm just going to talk, or tonight, I'm going to talk about just kind of the adult Medicaid service system. And then I will go into a little bit about the crisis continuum. There have been some pretty recent and significant changes to crisis services that are available. But I'll kind of give a general overview first, and then of course we can take questions at any time. So let me make sure my slides are working here. There we go. So I first just want to talk about some of the significant changes that happened within our Medicaid program for mental health. It's been about almost, not quite 5 years now. But within the last 4 to 5 years, there have been several significant changes that have allowed greater access to both mental health and substance use disorder services, particularly for adults. So the Medicaid program we had 5 years ago is not the Medicaid program we have today. And I think most of us would agree that's a good thing, these changes that we made. So several of those changes are, so first of all, this would be back in 2020, we expanded coverage of what we call medication-assisted treatment. So this is just meaning medications for individuals to taper off of any substances that they are dependent upon. So we have opioid treatment programs. They are the only providers that can prescribe methadone for substance use purposes. They previously were not allowed to be Medicaid providers in our state, but with this federal change, it was mandated that all of that had to be covered. So now we have those programs and services that are covered by our Medicaid program. And then shortly after that, we had our IMD waiver approval. IMD stands for Institution for Mental Disease. I don't like that terminology. It's old and antiquated and not great verbiage, but that is the federal terminology that they use to describe certain facilities that serve. And I'm sorry if you hear my dog barking, but that's the term used to describe facilities that serve individuals with mental health or substance use disorder issues in an inpatient or residential setting. So again, for adults, without this waiver, we were not able to use Medicaid funds to cover inpatient psychiatric stays for adults or residential substance use disorder services for any age because of this federal exclusion. So with this waiver that we now have, and we're actually almost into year 5, so we're ramping up for renewal of the waiver, This allows the Medicaid program to cover those vital services. So that means when an adult goes into a psychiatric hospital or a unit within a hospital for psychiatric care, and they're a Medicaid member, Medicaid will now cover that service like any other behavioral health service. And the same is true for both adolescents and adults who go into a residential substance use disorder facility. Previously, that was not covered, and now it is. So with that waiver, we were able to expand those kind of higher levels of care. And then shortly after that, we had Medicaid expansions. That meant there were a lot more adults who became eligible for Medicaid. So it was sort of strategic. We expanded access to services, and then shortly after that, eligibility was expanded. So now we have more people who are eligible, more adults who are eligible specifically, and more adult services available to those individuals. And this, I'm going to kind of go over the specific services that are covered for adults. I have the different sort of eligibility categories, but you'll see it's mostly all the same no matter what eligibility category an adult is in, but there are some slight differences. So we have some individuals who are in traditional sooner care, some in sooner care choice, and then there are some slight differences for adults who are covered through expansion. So, but those services include inpatient hospital services. So again, some of those services I just mentioned. So if you go to inpatient psychiatric care, either in a freestanding psychiatric hospital or a unit in a hospital, that's covered. Of course, medication-assisted treatment is now covered. And then outpatient behavioral health services provided by an agency. I will talk a little bit about what those specific services are, but the general service array that you would go get at an agency are also covered. Sometimes there is a small copay for certain services, as you'll see. Also, independent practitioner services. So again, that means you're not going to behavioral health agency per se. You're seeing an individual practitioner who is either a licensed clinical social worker or a licensed professional counselor or a clinical psychologist. They have a different, more limited array of services, but they offer some sort of specialized services to certain individuals. As you will see, one of the recent changes that we also made, previously, we did not allow independent practitioners of any type to serve and be reimbursed when they served adults. Within the past couple of years, we now allow independent psychologists to provide services to Medicaid members who are adults. Kind of the reasoning behind that is there is a lot of need for psychological testing and evaluation. That is primarily what a lot of the independent psychologists do and offer, that sometimes those services are not available at an agency as readily. So that is now open up to adults. For individuals who are under the age of 21, they can see any type of licensed behavioral health professional. Again, that would include someone like an LCSW or LPC. They can see any of those practitioners. But now we do allow adults to see psychologists as well. Psychiatric residential treatment facility, or what you might have heard of as a PRTF. Those are specifically for individuals under the age of 21. So that's not covered for adults. Again, adults typically would be at a higher level of care going to an inpatient or residential facility, depending on if it's a psychiatric or substance use disorder related event. And then residential substance use disorder treatment, as I just mentioned with the waiver, is now covered for both adolescents and adults, where previously it was not within the Medicaid program. So when we say outpatient agency services, what do we mean? So typically those can include things like screening assessment service plans. So that's sort of how services are initiated. A licensed professional will do an assessment and develop a service plan to figure out what an individual needs to receive and how frequently they need to receive services. And then the services include things like, of course, individual, group, and family therapy, rehabilitation or skill development, and then peer recovery support services. So those are services provided by peers, so individuals who have some type of recovery story themselves and are helping others kind of going through similar circumstances. And we now also offer what we call family peers. So there's that family to family element too, for family members who have gone through a recovery with a child or a family member, and then they can help other family members do the same. And then case management, which is a lot of linkage and referral to services. And then also crisis intervention. So if individuals are going through some type of crisis, there's on-site crisis service, mobile crisis services, and then what we call facility-based crisis services. So you can go to a crisis unit where you might spend 1 to 3 days there to de-escalate the crisis situation, or what I'll call a URC, urgent recovery clinic, which is more of a short-term assessment and stabilization facility. We'll talk a little bit more about the crisis continuum later on in the presentation, because like I said, there have been some pretty great developments in our crisis continuum in the last few years. And then again, if you're going to an independent psychologist as an adult, mainly what you'd be getting there is, again, they are similar. They're just a little bit more limited as far as the types of services you can receive, but assessments, all types of therapy, and then the biggie, developmental and behavioral testing and evaluation. That's what we know is a pretty big demand, and then sometimes there is a big wait for that. So we are hoping that by opening that up for adults to be covered under the Medicaid program, that would potentially help with that situation. And then as far as inpatient and residential services, these would include, again, acute psychiatric care in a freestanding hospital. We have several state-operated hospitals as well as private hospitals in the state, psychiatric hospital units, and then withdrawal management in a hospital. And then residential levels of care, again, residential substance use disorder treatment. So where someone's going and they're staying in a facility for a certain length of time, could be several weeks, several months. And then also residential withdrawal management. Those are a little bit short-term stays when someone is just needing to basically go through what we call detox, which is a higher level of care. But basically, most levels of care now through the continuum, we have tried to have coverage in our Medicaid program. So there's not a cliff where people drop off and no longer have coverage for something as an adult, which was sort of the situation we were in previously. I also want to talk a little bit about managed care, because that's the other, of course, big change that has happened to our Medicaid program within the last, it's been less than a year, I guess, back in April of last year. So I'm sure most of you have heard about this. So it's not making a ton of changes to the Medicaid program generally, but there are some differences. So obviously there's now 3 entities, Aetna, Humana, and Oklahoma Complete Health, that are managing the care for a lot of Medicaid members now. I think there's over 40 states now in the nation that have managed care. So we're not unique in that. But the Sooner Care Service Array, the limitation and caps on services, and the provider qualifications for services, all of that stays the same. So essentially, managed care entities can offer more, but they can't offer less. So right now they have to pay at least the minimum that we pay in our Medicaid program. They have to have at least the same limitations that we have. They can't have less. They can offer more, and sometimes they do. And then they can't have different provider qualifications for services. So a lot of that stays the same. But again, what differs is things like prior authorization processes, provider reimbursement, meaning the rate may be the same, but they may offer incentives or different ways that they reimburse providers. Obviously, the points of contact are different. And then they do have what are called value-added benefits. So as I mentioned, they can offer more, but they can't offer less. And that's sort of up to each plan to decide what they want to offer as these value-added benefits. But some examples of those are they use technology. There's something called Pix, which is a mobile app that does online mental health coaching. Sometimes they actually have member rewards for doing things like going to a follow-up visit after you've gone to an inpatient hospital. and then even alternatives to opioids. So individuals with chronic pain who don't want to use opioids, maybe because they have a history of dependence, can sometimes receive reimbursement for alternative therapies. And then some of the other benefits that might be offered by a different health plan in the Medicaid program is non-medical transportation, GED and career support, an over-the-counter allowance, meaning money to buy just like ibuprofen or things over the counter, excuse me, post-discharge meals, respite, and housing assistance. Again, all of this information is on OHCA's website if you're interested in looking at specifically what each plan offers. And that can also change year to year. I think they're going through an update right now. But something to be just aware of if you or someone you know is an adult in the Medicaid program and they're wanting to know maybe what the differences are between some of the plans. That is one of the things that is a little bit different between the plans, and some of these things can be quite helpful to members. Now I'm going to talk a little bit about our certified community behavioral health clinic. One of the things about our world is we like acronyms, right? So CCBHC is what we call them, or CMHCs. We have a statewide network now in the state of Oklahoma. We have expanded that over the past few years, but now we have the entire state covered by a CCBHC. And if you're familiar with community mental health centers or CMHCs, they're sort of enhanced versions of those. They provide 24/7 access to services to Oklahomans in their area, regardless of their insurance status or who's paying for their care. They are what we call our safety net providers. So they're there to make sure if an individual needs care that they're getting care. And they offer a comprehensive array of services, including mobile crisis and facility-based crisis services. They do physical healthcare screening and medications. So one of the things that CCBHCs do is try to integrate behavioral health and primary care or physical health. They have, of course, those other services of therapy, peer recovery support, and rehabilitation services, as well as employment support. And again, there might be some differences between CCBHC. Some of them may offer additional things. And I will show you a map here in just a second so you can kind of see, depending on where you are, what your local CCBHC is. So I know it's a little bit hard just to maybe see, but you can see the different areas and then you'll see which CCBHC is in that area. And I will say Oklahoma County and Tulsa County, we're making some changes to how that works. So there's going to be several that kind of serve those counties. But you can go to this website, Network of Care, and it will actually give you a map if you want to search for a particular service or if you want to find your CCBHC. You can go to our website, this website right here, and kind of look for what the local agency is in your area, and it will have their contact information. But this is just if you're wanting to direct someone to where to go or as a first stop, this is a great place to start, is to start with your local area CCBHC. And one of the things that CCBHCs are a big part of is our Crisis Continuum and 988. So I hope you all have heard of 988. There has been a lot of effort, I would say over the past year or so, to really get the word out about this mental health lifeline. So essentially, if it helps you remember, it helps me remember, it's sort of the 911 for a mental health crisis. So 988, it's a national number, so it's not state specific to Oklahoma, but we obviously have it in our state. We use a vendor called Solari to manage that system. And it's sort of the first point of entry for anyone who's experiencing a mental health crisis. And in addition to the 988 Lifeline, we've also been expanding urgent recovery clinics, crisis units, and mobile crisis teams. And I will kind of explain how those all work together. So this is just kind of an overview of how it works. So we have the 988 lifeline. So again, if you remember nothing else from my presentation, remember that anyone experiencing a crisis can call 988 and then someone will pick up the phone and can assist that person. But you call that line and then a number of things may happen. It may just be that someone needs to talk to someone over the phone. We have mobile crisis teams across the state that can go to that person to help de-escalate and assist that person. It may be that that person just needs a follow-up or referral to the community provider. And then we do actually have transportation providers across the state that can transport someone to a higher level of care facility if that is needed. So again, this is kind of how it works. So 988 is a national number, like I said, so it's not even Oklahoma specific. So if you have family or friends across the nation that don't know about 988, let them know that is a number available to them. When someone calls that number, they're connected to an individual who is a mental health professional, and that person can, again, de-escalate a crisis situation, connect them to available resources, and determine if there is sort of another type of intervention that is needed. Most calls are able to be resolved over the phone, but when needed, 988 will connect individuals to a mobile crisis team so that that team can go to that person and assist that person face to face. Those crisis teams may include a peer recovery support specialist and or a case manager, or maybe two peers, two case managers. And then there is a licensed mental health professional that is involved in overseeing the care that's provided by that team. And sometimes, again, that's all that's needed. But when appropriate, there might be follow-up services provided to callers. These services may be provided by a community provider, or 988 crisis specialists may follow up by phone within 24 to 48 hours. So this could happen either at the point of someone just calling the phone, could be a follow-up and referral made, or with the mobile crisis team, if they feel like they're able to resolve it there, then they might do a follow-up after that to make sure that person is doing okay after the crisis visit is done. And then when needed, we have those facilities, those urgent recovery clinics, I have a typo, crisis stabilization units, and inpatient psychiatric facilities. So if the licensed mental health professional determines that someone needs to go to a facility, we have now a network of vendors who provide transportation for that crisis situation, specifically for individuals who are needing crisis care or needing to go to a crisis facility, of some sort. And we've also been able to get that covered by our Medicaid program. So that's also a Medicaid service that's available to members. But they don't have to be a Medicaid member. I should clarify that. That's available to anyone experiencing a crisis. But we are able to cover that now through our Medicaid program. So I feel like I've talked a lot and fast, and I always do that. And I get to the end and feel like I talked like a lot and fast. But that's kind of just a general overview, and I'm happy to take it's only 6:30 and we have a half an hour, so I'm happy to take any questions or comments from you all.
The biggest question I get is transportation. So when you say there is in that array of services, transportation, is that a 988 response, that there's somebody there that's going to be able to dispatch a cab or a Uber or somebody to go pick somebody up in, let's say, Kenwood, Oklahoma, if you know where that is?
I don't know where that is, but the basic answer to the question is yes, if they're experiencing a crisis of some sort. And it's not a cab or an Uber. It's we have a set of contractors that we utilize, that they utilize special vehicles designed for this purpose to go and pick up that person and take them to a facility if that's determined that that is what they need. It's anywhere in the state.
Who makes the determination?
So that could be, and it could happen at a variety of different places. So it could be that the 988 person receiving the call, but most likely it would be like if a mobile crisis team went out and the licensed professional thought that's where they needed to go.
Okay, so Kenwood is east of Pryor, Oklahoma. It's actually east of Salina. And it's way out in the boondocks. And so those are the kind of questions I get. I cover the northeast part of the state. And so when I go to my coalition meetings and we talk about 988 and other resources, I'd say transportation. It's not, that's a grand mental health area, and they do have the mobile units and they give the sheriffs up there all have iPads that Grand has provided, so they've got good coverage. But that to me is the area where the system seems to be lacking.
Yeah, and I will say this too, and I usually say this in my presentations, and I hope this doesn't happen, but of course, we understand that not everything works perfectly all the time. So if you do ever encounter an issue accessing a CCBHC or accessing transportation, please let me know or anyone else at the department. We always want to know that so that we can address those issues. We've built this system and we're trying to make it work as seamlessly as possible. But as I think most people know, sometimes there are hiccups and things don't work perfectly. We need to know that so that we can ensure, especially in these situations when someone's in crisis, that they are getting what they need when they need it. But here I finally was able to find, here is the map of who is kind of responsible for each area. You can see ride care is responsible for the vast majority of the state. But the whole state is covered by one of these entities for transportation for crisis.
Grand has changed their name. They're no longer Grand Lake.
Yeah, they're just Grand now. We need to update that.
Yeah, we need to update this map. So Grand, okay. Well, I cover Grand and Creox, so they're the actual CCBHC is responsible for transportation.
Yes, they are the two that have chosen to do that for their area.
That's a contractual obligation.
Yes.
I have a question.
Yes.
So if there is a crisis event and the mobile crisis team is dispatched to a location, let's say that we're down here in Love County, okay? Um, in the event that the licensed professional determines that they do need that higher level of care, does the crisis team stay on site with the individual until somebody is there to take them to that facility? Or how does that work? Do they get transported to like an emergency room for holding, or what does that look like?
They don't get transported to another place. And that's a really good question. My assumption is, and that they stay with that person until the transport gets there. But that is something I can clarify. Again, I personally don't work a lot in the crisis system, so some of these types of questions I can get answers for you. I think, of course, the goal is for the crisis team to always stay there until that person gets transported. There could be situations, though, where they get another call or something and they would have to leave. But ideally, yeah, they're going to stay there with the person until they get transported.
So something that I have encountered now, my disclaimer is I'm only a CPR. It says I do not hold any amazing licenses like some of you guys do. But I do have a lot of ladies that I work with because I'm part of the Toughest Mother initiative. And one thing that I ran into was one of my ladies, for whatever reason, found herself halfway across the state, somewhere she didn't need to be, and there was nobody that was able to get to her at that time. And she was like, I don't want to do this by myself. I feel like I'm going to do something I can't come back from. Can you stay on the phone with me? If somebody gets here, can you ask them not to leave me? So I think especially with the the demographic of people that I work with and that a lot of us work with, it's some of us the fear of being left alone, man. Like that's a real thing for some people because it's a very scary experience to have a break with reality, let alone, being told that, hey, the best place for you is going to be A, B, or C. You know what I mean? So, yeah, if you could find that out and maybe let us know, that would be something that would be like an element of comfort that we could tell people. You know what I mean?
Yes, of course. And I will say too, one of the challenges, like I think it was Robert was talking about, it sometimes does take a little bit of time to get to where that person is, whether it's a mobile crisis response or a transporter getting to that person. If you're out in the panhandle or something, it can take a little bit of time. So, yeah, I think point taken that as much as possible, we don't want to leave folks alone. I will say, if someone just needs a voice, 988 is always an option for people to call. Sorry, I'm writing down, so make sure I get back to you.
The other concern I have is people say that the transport is one way, especially if it's across county lines. So if somebody in Delaware County goes to treatment in Tulsa County, they can get them there. But then when it comes time to get them back from Tulsa to their home, that doesn't have the same. So that's another area for you to look at in terms of if we really want to make this work, it's got to be two ways. It cannot be a one-way ticket and then leave it up to the family or other, because we're talking high poverty here. So, and so that I'm raising this as a challenge to address, not as a criticism or just an observation. I've heard it, and that's coming from the communities. The Evolution Foundation works with coalitions who have community-based contacts, and that's where we're out there. The rubber meets the road. We hear about it, and that's some rubber on the road that needs to go both ways.
Yeah, so that is something we have identified as a challenge. So the kind of a limitation of the transport that I'm talking about is it's funded and mandated for someone in crisis. So meaning, once they are leaving the facility, they're no longer in crisis, and so it doesn't meet that criteria. But in an ideal world, if someone had Medicaid coverage, there is transportation that can be accessed for just regular non-emergency for appointments and getting back after discharge. We have heard that there are a lot of challenges with that system, though, and often, because of the timing and the notice that you have to give, it doesn't work a lot for to getting someone home after discharge. So, yeah, that's certainly a challenge that we have identified, is then getting them back home. There may not be a great option for them all the time.
I look forward to hearing the solution to that.
Yeah, we're going to be rethinking about that. And of course, if you have any ideas, please let us know. We're always open to any creative solutions anyone might have.
I have an idea, and it has to do with paying the sheriff's deputies, the ones that transport him there. They get reimbursed. Reimburse them both ways. Just say, okay, let's get them home. We got to get them home. That's the bottom line. These are poor people, and we can't put it on them.
If you don't get them home, you're just creating another crisis.
Exactly. Then they'd be in a crisis again. But the crisis would, yeah, okay, Alan, thanks.
Yeah. But I think the issue, what you're talking about, is that 72 hours for Medicaid. If you gotta, if you're getting sooner ride, right? That 72 hours in,
Yeah.
yeah. So, yeah.
So Melissa, we're pretty much bringing up issues that we hear in the community on the regular. I think most of us work in some of those rural areas where we've had these stories. We try to connect them back to the treatment providers,
Mhm.
like the CCBACs. We know it happens, but again, they bring up a value point because we always hear about they get there, but they can never get back. So we're just bringing it to you guys.
Yeah, and I know some of our providers and like some of our, like our state operated crisis units will do that. I just know that it's not consistent. And so that's not great, that's something that we ideally would have a consistent way to get everyone back home, wherever they're at.
I brought it up as an observation, not a particular criticism. I mean, it's a critique, but it's not a criticism.
It's a challenge.
It's a challenge, exactly.
How about that? And we have lots of those, lots of those to address in our state.
So it's not possible to facilitate that through the inpatient provider getting them back.
I'm not saying it's not possible. I'm just saying it might depend on who the provider is. Sometimes there might be resources available to do that, but I don't know that that's
Makes sense.
it's not across the board. Yeah.
It's going to require a line item budget change.
Yeah,
Robert
that's the challenge.
Robert keeps breaking all of it. That's all right. That's all right. It's a big elephant we're eating. Yeah. Yeah. But what we can do, and we just need to keep doing that.
I have a general question, if I may ask. I am a parent support partner, so I'm learning about resources that I haven't been familiar with. And this is one of them, and I'm just super, super impressed. And I don't consume a lot of media, so if you're running ads, they're probably working. I just hadn't come across it myself. But I'm hearing some of the questions and you answering them, but just looking at what is in place and the resources being offered, it's really neat and encouraging for someone who isn't aware of this program to be learning about it. And I'm a little bit curious, how often is the hotline utilized? And clearly there are some questions about the transportation. So it sounds like these services really are being used. And I'd just love to hear a little bit more about that part of it.
Can you see the website, the web pages that I'm on right now?
I can, yes.
Okay, because I'm going to try to find, bear with me, there's a dashboard what will tell you exactly that.
Oh, wow.
Here we go. Give it a second. So about 5,500 in the past 30 days. So, and this will tell you the answer rate, average speed of answer, simulation rate. There's a bunch of data in here that you can look at if you're interested in just seeing how it's being utilized. And so this is done in partnership with Solari. Again, they manage the 988 crisis line in Oklahoma. But yeah, you can see July was a big month, almost 7,000. So between 5,000 and 7,000 each month.
Wow. And dispatch is the actual going to the site on dispatch?
Yeah, that'd be a mobile crisis team.
Mobile crisis team. Wow. Well, thank
so
you.
as you can see, most of the time the call itself resolves the issue, but then we also have, when needed, the mobile crisis team will go out to someone.
And law enforcement kind of works together with that. Okay. It's amazing how much just talking to, not just as in it's a little thing, but it's amazing the power of talking to somebody. So thank you for sharing this page.
Yeah. And, sometimes people might say, well, is it okay to call? I mean, if you just just call, if, better to err on the side of, if you feel like someone needs a call or you need to call on someone's behalf, just call. No one's going to be mad at you for calling you and, you not needing a high level of care. If you just need to talk to someone, that's fine. That's what it's there for.
Okay, thank you for telling me more about that. As I, meet with other people, and if I ever feel like I'm talking to someone and I just don't even know what to do, this sounds like a great option. Thank you.
I actually had a question, and I just want to make sure I'm reading this right. So it looks like, so for July, there were like roughly 6,900 crisis calls. Is the dispatch volume a subset of the crisis call volume?
I believe so, yes, because you wouldn't have been, let me think about this. You wouldn't have had a dispatch from 988 unless you called 988. So yeah, it would be out of the 6,900 of those, a little over, what is that, 10%?
Yeah.
So about 90% are resolved over the phone, about 10% result in them sending out a mobile crisis team.
I guess I had another question. What would be the criteria for a mobile crisis team to be dispatched?
So I will say I'm not a clinical person, so I can't really speak to that, but it would just be essentially whoever is on the line, that licensed professional determines this can't be de-escalated over the phone. This person needs more intervention. So whatever that sort of licensed clinical staff person decides needs to happen is kind of what's directing that decision.
Okay, no, thank you. That's really helpful. I appreciate learning about this.
Can you also see by county?
I don't see it on here, but that doesn't mean you can't do it. I just maybe don't know how to do it. 'Cause it looks like
I was just curious
there's
if it was
all kinds of different buttons and things here.
down from rural to.
But again, I can see if that's something that is we can do, and I just don't know how to do it, or if that's something that we can share.
I agree, though, to see about 90% of them being able to be stabilized without having to send out teams. That's pretty good. I'm assuming the 149, the 911 diversion is. I'm assuming that's for that 5-month period or whatever, 6-month period.
Doesn't really say.
Okay.
Apologies, I haven't looked at this data in a second, if you can't tell. So I'm not 100% sure if that's monthly or over the July to December period. I would guess, yeah, I'm not sure. So again, I can try to follow up and get you guys
That's all right.
answers to that.
Here's another question. What if someone is an Oklahoma resident, but they're just over the border? Like say they're in, I'm trying to think of a Arkansas town. They went to the Arkansas town because they went to the grocery store or whatever, and they ended up in crisis. Would a dispatch team cross state lines? Probably not, but I'm pretty ignorant in this regard.
So again, I'm trying to remember. I think the way that it works is that if they called 988 from that location, I think it would go to that state's 988 line. I think there's something about like wherever.
I think that's how it works too with your because like 911 goes to your local area.
And then that state system would come into play for that person instead of ours.
Thank you.
It's a great question though, because I live down in Durant and lots of people did shopping in Sherman Denison.
I'm up in Bartlesville, so I'm about 7 miles from from Kansas, basically. So
And you might have people coming from Kansas to Bartlesville that would be getting, that would be in that system or that situation more so maybe.
I just want to say that looking at your screen and like up here in the top right corner, the top 5 referral sources, um, I think it's pretty amazing that 64% of people referred themselves. Like it's kind of reassuring for me to know that people really do know when they need help and they're making those phone calls versus just sitting there and either doing something they can't come back from or doing something that's going to land them in prison for the rest of their life, you know? So, I mean, I know that we're still on a journey as far as our system, whether we're talking about our mental health, substance abuse system, our legal system, our juvenile system. I know that we're still on the road to greater things, but the realization of how far this has come just in the last 5 years, let alone the last 10 years. I mean, that gives a lot of hope, you know what I mean? I love that.
Yeah, we're trying to make it better, understanding that it's not perfect.
Did
So,
you did you
and
see
always asking you all to help us make it more better.
did you see
Make it better and better.
Marilyn's question in the chat about will they ask immigration status if they're calling on behalf of one of their consumers? Do they ask
No,
that?
I mean, they won't ask that specific question. They do try to gather some basic information, but I don't think anything is required. So like if someone doesn't want to share any information, they're still going to be able to get assistance.
I was thinking it was operating like the old suicide hotline. You could just call and you could do it anonymously and kind of talk through that stuff. It's I
Yeah.
guess, but if you're gonna get somebody dispatched to you, they're probably gonna get your information. That's a different deal.
Right. And like they try to get, obviously if you call on your own phone, they would have your number, but that doesn't always happen. It could be like I'm calling and I'm handing the phone to someone. Obviously they're going to try to get their contact information so that if they do need to do like a follow-up or anything, or need to send a community provider out to them or to reach out to them, they have their contact information at least.
does anybody else have any further questions? Or Melissa, is there anything like final words you'd like to say before we stop the recording?
I will just say, yeah, if I always encourage people to, just if this information was helpful, you can go to our website and kind of explore. Again, there's also the service directory, so the network of care. If you go to treatment and service directory, where you can also find resources. So check it out if that's something that's interesting to you or helpful to you. And then, of course, I think you'll have my contact information. So also just, again, we're open to feedback, positive and negative. So if you do encounter, you had a great experience, or maybe, you didn't, or someone didn't get the help they needed right when they needed it, we always want to know that. So please feel free to let me or someone at the department know when our system maybe needs some challenges, as we said, addressed. So all that to say, we love to hear from you. We're trying to make, again, the system better and better as we move forward. So please let us know what we can do better.